Hi, everybody. Thank you for pushing through on what is a very long day. I cut my slides down to be about half an hour. We're going to get through it, but I encourage you to ask questions, and there'll be lots of time at the end. I will stay as long as you stay to make sure we get through everything we need to get through. All right, so we're going to talk mainly about pulmonary arterial hypertension, but I thought we'd take a step back and start with just, if I could work this, no? Can't work it? Dyspnea. All right, so dyspnea is just a fancy way of saying shortness of breath, and you'll hear this all the time. Shortness of breath is pretty non-specific, and it's different for everybody. It can be a sensation of just not being able to get enough air in, or just feeling like you're breathing more often than you should. It's the most common complaint that patients come to see lung doctors or heart doctors with, but it's also one of the most common complaints that patients who have no lung disease and no heart disease feel. So let's talk about the causes of dyspnea. And to understand dyspnea, you got to go back to med school with me and start with circulation 101. So if I don't have a mouse, let's see. Is there a mouse? Yes. I don't like pointers because it's got a little bit of a tremor. It gives me away. All right. So let's start in the middle with the heart. Everyone can see what I'm pointing to here? The heart's got two sides, a left side and a right side, and they're separated by a wall down the middle. Every time the heart pumps, the red side here, the left side pumps blood that has lots of oxygen out to feed the body. That provides the oxygen and the sugar you need to do anything. That's the food of life. So after the body takes what it needs, all the oxygen out, that blood goes back to the right side of the heart, which pumps it to the lung, where with every single breath, you breathe in fresh oxygen, like stocking up at the grocery store, and then it goes out to do it again. Back to the left heart, out to feed the body. Body takes what it needs, back to the right heart, through the lungs to reload, around and around in a circle. Left heart, body, right heart, lung. That's why we call it the circulation, because we're not very creative. So this is what keeps us all going. Remembering that every single part of the system can actually cause shortness of breath. So if you've got a problem with the lungs, either COPD or asthma or anything wrong with how the lungs work, certainly you'll feel short of breath. If you've got something with the heart, it's not pumping well, you've had heart attacks, that can cause shortness of breath, right down to the bottom of the system. If the legs are weak, they require a lot of extra fuel from the heart or the lungs, and that makes you feel short of breath. Or if you're just carrying a lot of extra weight, every single one of us has to carry every pound we gain every day of our lives. So it's extra work, just like carrying that weight in your hands, if you were carrying two weights around. So shortness of breath can be caused by any part of the system. It's one of the most common complaints and one of the most complicated to sort out. In patients who have scleroderma, we think about two specific causes of shortness of breath because they're more common in patients who have scleroderma. And in the lungs, we think about interstitial lung disease, which patients with scleroderma get much more than the general population. And they also get pulmonary arterial hypertension, which is not really a cardiac disease. It's kind of where the heart meets the lungs, and we're going to talk about that. So these are two diseases that anybody can get, but that are more common in patients who have scleroderma. So we're going to focus today on pulmonary arterial hypertension. First, my disclaimer, and we're going to fly through these slides. Pulmonary arterial hypertension is not the same thing as pulmonary hypertension. There are a lot of diseases that make up pulmonary hypertension. Pulmonary arterial hypertension is a specific disease where the vessels in the lungs go crazy. And I'm going to tell you more about that. It's very different than pulmonary hypertension in general. There are 5 different categories of why is that on there? I don't know how to get rid of it. Hopefully it'll go away. There are 5, nope. I guess I should have another disclaimer that I'm not technologically savvy. Oh, there it is. All right. So there are 5 different categories of pulmonary hypertension. Pulmonary arterial hypertension, the one we're going to talk about today, is just one of them. Okay? And just to show you the list of things that are included in pulmonary hypertension, that's the list. We're just talking about one of those. And the reason we're going to talk about one of those is because it's the most common, or the thing that we worry about the most in patients who have scleroderma. So there's my disclaimer, and let's move on to pulmonary arterial hypertension, the topic of the day, or at least the afternoon. All right, back to our circulation, and this is going to be the thing we work off for most of this talk. So pulmonary arterial hypertension is in its most basic form defined as high blood pressure in the blood vessels of the lung. I like to think about balloons when I think about the blood vessels in the lungs because they're easy to understand. It makes it clear for me. The blood vessels in the lung should be like this balloon, floppy, easy to blow up, lots of fun. So when the right side of the heart tries to pump that blood through the lungs, it doesn't have to do a whole lot of work. It's just nice and easy. The right side of the heart's not built to do work, so it likes when the balloon is nice and floppy. Pulmonary arterial hypertension is when the blood vessels in the lungs go nuts, for lack of a better explanation. They change and they become more like the stiff balloon. The balloon you make balloon animals out of, where your eyes just want to pop out of your head, they're so hard to blow up. Just like it is hard to put air into those balloons, when the blood vessels get stiffer and change, it is very hard for the right side of the heart to pump the blood through. The stiffer the blood vessels, the more the change, the more the heart strains. The consequence of that is, why is it going backwards? The consequence of that is as the pressure in the blood vessels of the lungs go up, the right to the heart strains more, and it has a hard time getting the blood through the lungs. If it can't get the blood through the lungs, it's harder to absorb oxygen in the lungs. Remember, oxygen is essential for doing work. It's also hard to get the blood to the other side of the circulation to feed the body in general, to send energy to the muscles to do work. And this can result in shortness of breath. And this is just one way to get there. Yes, question in the back.
You have a leaky heart valve. Does that affect your breathing?
Absolutely. We went off. I'm having all kinds of technical issues today. All right, so absolutely a leaky heart valve can cause shortness of breath. A leaky heart valve can also cause pulmonary hypertension. That's one of those other forms of pulmonary hypertension, very different than the diseases we're talking about today, but absolutely fits on the list of things that can make you short of breath. And one of those things we have to rule out when we're thinking about pulmonary arterial hypertension to make sure we know which one we're dealing with, because the treatment is very different. All right, so who gets pulmonary arterial hypertension? Well, it's actually a quite rare disease. About 1 in 100,000 people in the general population will develop pulmonary arterial hypertension. It's much more common in women than it is in men, and the average age of diagnosis is in the mid-40s, maybe up to the mid-60s. It's not quite as rare in patients who have scleroderma. It's actually more common. About 1 in 10 patients who have scleroderma will develop pulmonary arterial hypertension. It is more common in patients who have the limited form, the CREST syndrome, but it absolutely can happen in patients who have the diffuse form. So if you take the patients who have scleroderma, 1 in 10 will get PAH. If you take that 1 in 10, 75% of them will have the limited form, 25% of them will have the diffuse form. The time to diagnosis from the development of the disease and the development of symptoms is on average about 1.5 years up to 2 years. We want this number to be shorter. And fortunately, in patients in scleroderma, that time is generally shorter. The reason it's shorter and we're quicker with the diagnosis is because you guys have good doctors. They screen you. They think about it. They have a high level of suspicion. So patients who develop pulmonary arterial hypertension and have scleroderma, because their rheumatologists, their pulmonologists, their cardiologists recognize that they're increased risk, are always looking for it, which means they find it earlier, which is a good thing. All right, signs and symptoms. We are cranking through. So what are the symptoms? They are incredibly nonspecific. Shortness of breath, usually exertional. Sitting still, you're usually not short of breath. It's when you push the system, like stepping on the accelerator. That's when you notice that your heart can't get the blood through the lungs to give you the fuel you need. So the symptoms early on are not at rest. It's really when you exert yourself. And what you find over time as you develop pulmonary hypertension, that the easy things that you do just get a little harder to do. Usually run up 2 flights of stairs. Early on, you run up 2 flights of stairs, but you're winded at the end of it. Then suddenly you're walking up 2 flights of stairs. Then you're walking up 1 flight of stairs. It's only as it progresses that the symptoms happen with less and less exertion. So shortness of breath is the most common early sign, and it's usually only when you're pushing yourself, and then it gets harder. Okay? Fatigue and weakness. Why is that? Well, remember, this circulation sends all the fuel around so you can get up and run, get up and walk, do what you have to do in your daily life. As it fails, to send that fuel around or has a hard time doing it, you slow down, you have less energy, you feel exhausted. All of you are thinking, I am already tired, right? Yeah, I'm thinking it too. These are non-specific symptoms. So that's why we have to have an index of suspicion, why we're going to go through all the other things we have to do to figure out what you got. Next thing, edema, swelling in the ankles and sometimes in the abdomen. You notice your pants are just getting tighter and you didn't just have Christmas dinner, right? Increasing swelling in your ankles, your feet, sometimes going up in the calves, your belly swelling, not because of fat or weight gain, but because of fluid gain. These can be some of the signs. This usually develops a little bit later. Low oxygen, usually not when you're sitting still. When you're sitting still, you have enough oxygen. It's again when you move around, when you press on the accelerator, when you're burning up oxygen to do work, your oxygen levels can start to fall, because the circulation's not working well enough to reload the blood with oxygen to keep up with how much you're using. So low oxygen, new low oxygen, progressive lowering of the oxygen can also be an early sign of pulmonary arterial hypertension. Palpitations, feeling like your heart is racing, especially when you exert yourself, or new development of an irregular heartbeat. This can happen just because, but this can also happen because of pulmonary hypertension. And then there are what we call the alarm signs, at least what I call the alarm signs. These symptoms we only find in very advanced pulmonary arterial hypertension. These are not the presenting signs of pulmonary hypertension. The ones we talked about before are going to happen long before. So this is chest pain or pressure when you walk around, when you exert yourself, angina. Just like somebody who has heart attack kind of disease can get pressure in the chest, patients who have advanced pulmonary arterial hypertension can also get pressure in their chest when they exert themselves. Lightheadedness or dizziness, again, a very late sign in pulmonary arterial hypertension, but definitely one of the more worrisome symptoms. But I call them my alarm signs because I expect to see them very late in the stage of disease and in more severe disease. Every single one of the symptoms on this screen you can get for another reason, or 5 to 10 other reasons. So it's always an index of suspicion, and then you go looking. All right, so now let's go looking. All right. So as we think about it, it brings us back to that sign. We've got to think about all the things in this system that can cause shortness of breath. And this is a very short list of them. There are lots more. First, so we go through a very systematic process of ruling out one thing after the other. So first, we rule out the common things. Left heart disease. This is actually the most common cause of pulmonary hypertension in general. This is not pulmonary arterial hypertension. This is where the leaky valve usually fits. This is where the heart attack disease fits. This is where left-sided congestive heart failure fits. And this is the most common cause, so before we go looking for the rare one, we got to make sure you don't have the common one. So that you'll get an EKG, almost everybody will. Sometimes if we're really worried about heart attack kind of disease, we might do a stress test. And if we're really worried, we might do a left heart catheterization to look at the blood vessels that feed the heart to make sure that's not why you have shortness of breath. Then we can look for things that can look like pulmonary hypertension, pulmonary arterial hypertension. Look to make sure you haven't had a blood clot that swam from the legs or wherever and blocked up the blood vessels in the lung. That's another form of pulmonary hypertension and certainly can make you short of breath. This is what you guys have heard about on the TV, the DVT and PE, pulmonary embolism. We make sure that didn't happen to you, and that is usually with a special kind of chest x-ray called a VQ scan or a CAT scan. You guys know what the CAT scan is. You lie on the table and the round donut goes around and around and looks at the lungs. And usually if we're looking for clots, we'll give you contrast or dye in an IV to make sure there are no clots there. And this is probably the most important pre-screening test here, is thinking about lung disease. Right at the beginning I mentioned that patients with scleroderma get pulmonary arterial hypertension, but they also get interstitial lung disease. So this is probably the other thing that we have to make sure that we look for and rule out as we think about whether or not this could be pulmonary arterial hypertension. And we screen for that with lung function tests and a chest CT, sometimes a sleep study. So every patient with scleroderma who is developing shortness of breath, we have to keep pulmonary arterial hypertension in mind, but we also have to keep interstitial lung disease in mind. The PFTs and the CTs are probably the most important screening test, before the echocardiogram. And the echocardiogram is the most important screening test overall for all patients with pulmonary arterial hypertension. The PFTs and CT are almost as important in patients who have scleroderma. And with the PFTs, sometimes you can actually rule out the likelihood of pulmonary hypertension, but you're still going to end up coming back and getting the echo. All right. You guys all know what the echo and PFTs are? Yes? Any questions? All right, good. I love talking to an informed audience. All right, so you remember my disclaimer from before that there's so many different kinds? Well, the echo, the PFT, everything else I just talked about, it's a screening test. It's pretty good, but it's not perfect. It has a limited ability to tell us, do you have pulmonary hypertension? It's pretty good to say probably, but it's not really good at telling me, is it pulmonary arterial hypertension, the rare one, the one I'm really worried about, or is it some other form of pulmonary hypertension? It can give us clues, but the truly diagnostic test to figure out if your blood vessels have gotten stiff, if they've turned into that, like those stiff balloons, is something called a right heart catheterization. Now, this always scares my patients when I tell them about it. It shouldn't. This is the diagnostic test that can tell us, do you or don't you have it? Rule it in, rule it out. It also tells us the severity, how much the blood vessels have changed and how much it's hurting the heart. How hard is it for the heart to do its work, keeping that circulation going? And it's absolutely essential in most cases to be able to get the medications that we need to treat you. And also helps us figure out what's the right medication, what's the right combination of medications. It is, however, an invasive procedure. It's not a high-risk procedure. So I'm going to take a pause here. Most of us have heard about catheterizations. Yes, everyone's heard of a catheterization? Yeah. So catheterization is a general topic for meaning you put a tube into a blood vessel and measure stuff. The catheterization that most people are familiar with is a left heart catheterization. That goes into an artery. Arteries are high pressure, they bleed. That's where they talk about risks of stroke and kidney damage, yada, yada, yada. It's a worrisome procedure. If you need it, go for it. If you don't need it, walk away. The right heart catheterization is a completely different beast. This goes into a low pressure system. It goes into the same system where you draw blood when you give labs at the hospital, or it doesn't bleed. You go home with a Band-Aid. We usually approach it through a bigger blood vessel, either the jugular or the femoral vein in your groin, but it's still a low pressure system. So it does not bleed a lot. There's not a risk of stroke most of the time. The risks are real, but not as severe as left heart catheterizations. So this is a different kind of catheterization in a low pressure system that doesn't bleed. It's not zero risk. The risk of complications with this procedure is about 1%. And they actually studied this across the US and Europe about 3-4 years ago, and that verified that number. It's about 1 in 100 without any complications. The complications are usually mild, but they can be severe. So because it's a low-risk procedure, if we need to do it, we don't really pause. We just do it. But if you don't need the procedure, everything says you don't have this disease, then we don't take the 1 in 100 risk. But it's not the kind of thing you should lose sleep about. This is not the high-risk procedure. Yes?
This may be a little bit off topic. I had my first right heart cath 2 weeks ago.
Okay.
A thrill, I cannot begin to tell you. I have a latex allergy.
Okay.
So I have a question for you because I know what happens, but I need to know whether this is SOP at every place I would get it done.
Okay.
Does anybody make a Swan-Ganz catheter that has a balloon on it that is not made out of latex?
No. So everything else we can do latex free.
Yeah.
The balloon is not, but it's not a huge amount of latex and it doesn't really touch anything. So as far as I know, and I'll double check, there is not a latex-free Swan-Ganz. Actually, no, I lie. I take it back. There is. It's hard to find. It's very hard to find. So there is a latex-free Swan-Ganz catheter. It's not the kind of one we can leave in. It's hard to find, but there is one. It's just not common to find. Okay. Let me get back to you at the end of the talk, and if I can't come up with the name, I'll send it to you by email, or you can email us. But it's hard to find. Yeah.
So just to be clear, that's not a first screening test.
This is not the first screening test.
Everything else first, and then if you suspect it, then you would go this approach.
Yeah, so it depends on the patient and depends on their symptoms. If they have all the things that scream pulmonary arterial hypertension, then we'll jump to the echo, and if the echo says think about something else, we'll stop. But if the echo says maybe, maybe not, catheterization. If the echo says for sure, catheterization. If the echo can't be read, for whatever reason they couldn't see the picture well enough, and you have all the other warning symptoms, and you have scleroderma, and so your risk is higher to start, it's better just to know for sure than to delay diagnosis, catheterization. Yes?
If you've had, like, if you have the shortness of breath and that kind of stuff, you have all those type of symptoms, but you've had the echoes, you've had the CAT scan, you had all that other stuff. And you still got the pulmonary issue, you know, as far as like your test isn't 100% for the pulmonary, but everything else looked okay. Do you still think that you should take it a step further for early prevention, or?
So, two questions. The first thing is there are certain specific parts of the lung function test that if those are normal, especially in patients with scleroderma, almost certainly there's not pulmonary arterial hypertension. And it's actually more reliable in patients who have scleroderma than anything else. It's the diffusion number, the diffusion capacity at the bottom of the test. So it's not great for screening everybody with pulmonary arterial hypertension, but it's actually quite reliable when we look at that one number in particular in patients who have scleroderma. Now it gets confused if you also have a little bit of schmutz in your lung, a little ILD. Incredibly common to have just a little bit, just enough to make your lung function test a little abnormal. Not necessarily to be significant, but to make that less of a reliable marker. So if that number is normal, often we can say with a good amount of confidence there's probably not pulmonary hypertension here. If that number is abnormal because you have schmutz in your lung, you have ILD, then we need to look at other things that might help us. The echocardiogram is then the next big thing to look at. It can give us a lot of clues about whether or not you have pulmonary hypertension. If the lung function test, the echoes, everything else is reassuring, then probably it's not there. If we're wrong, pulmonary arterial hypertension doesn't hide. It is going to evolve. This is a progressive disease, and if it hasn't been there and the symptoms haven't changed in 6 years, it's probably not there. It doesn't mean it can't evolve, but pulmonary hypertension is a disease that changes over time. And so if the symptoms start mild, if we don't find it and treat it, it does progress.
But if the lung test, the one where you go and you do all the breathing, that's not great, but the echo is okay.
So the short answer is it's different for every patient.
Oh, okay.
It depends on the combination of things we have. If absolutely every test is normal and stays normal over time, then it's probably not. It depends on the test, and different patients have different abnormalities on the lung function tests. But if they've done all of them and over time they are all normal, it's probably not there. If the symptoms are not changing over time, it's probably not there. So the echocardiogram and the lung function tests and not desaturating with walking, if all of those things are normal, then almost certainly it's not there. If there's still enough of a suspicion, if the symptoms are still progressing, if you just want to know for sure and it's keeping you up at night, those are all reasons that might push us towards doing the definitive test. Even though it is some risk, it's not high risk, and if enough things are raising the question, sometimes you just need to answer the question. Okay? All right. So at this point, either when they start to think about pulmonary hypertension or someone has a new or an increasing shortness of breath, raising questions for pulmonary hypertension, increasing swelling, falling oxygen levels, worrisome lung function tests, or a concerning echocardiogram, at any point along this line, most primary care doctors, most rheumatologists, pulmonologists who don't do pulmonary hypertension, or cardiologists who don't do pulmonary hypertension will usually refer patients to see a specialist at this point. I lost my mouse again. There it is. We'll usually refer them to see a pulmonary hypertension specialist, and we will take them for evaluation anywhere along the line. If the question is raised, then sometimes we just need to help answer it. And I'm going to pause here because a lot of times you hear that pulmonary hypertension is a pulmonary disease. Well, the blood vessels that are causing the problem are in the lung, and sometimes you'll hear it's a cardiac disease. Well, the organ that suffers because of the blood vessels is the heart. So pulmonary hypertension is actually best thought of as its own specialty. It is where the heart meets the lungs. It's where the heart and the blood vessels communicate. And that's why you'll see people like me, a pulmonologist trained in lung medicine and ICU medicine, who specializes in pulmonary hypertension doing this talk. And you'll also see cardiologists, people trained in heart disease, heart attacks, and heart failure, also doing pulmonary hypertension because that's where our two organs meet. And it's split about down the middle of the road for the people who do pulmonary hypertension. There are also rheumatologists who subspecialize in pulmonary hypertension. So when you're looking for a doctor to take care of you or evaluate you for pulmonary hypertension, it's not necessarily what their subspecialty is do they subspecialize in pulmonary hypertension. As we started out talking about, it's a pretty rare disease, and even in patients who have scleroderma, it's still not so common. And so the reasons they usually get referred are multiple. First, because people are worried and it's a worrisome disease. And second, because we got to make sure we know what your shortness of breath. Is it really PAH or is it some other form of pulmonary hypertension? Is it even pulmonary hypertension or is it lung disease? Is there something else that this could be, and we need to rule those processes out? Second, patients generally do better when they get diagnosed early and get treated early, which is why I'm so glad that all the doctors who take care of you, the lung doctors, the cardiologists, the rheumatologists, are really good at screening early so that you present early. And finally, the treatments are complicated. The drugs we use to treat pulmonary arterial hypertension are used in just about no other subspecialty. So getting the medication can be a challenge, titrating the medication can be a challenge, knowing the side effects and troubleshooting the side effects can be a challenge. And so these are some of the reasons why you need a subspecialist to take care of you. The only place that our drugs get used with any frequency other than pulmonary arterial hypertension is scleroderma. So you guys might be on some of them already. But what are the goals of treatment? The goal is to essentially relax the blood vessels in the lung so the heart can do its job and keep that circulation going. Or put in very simple Akaya terms, take the stiff balloon and make it behave more like the floppy balloon, right? Something you can follow, something I can follow. So all our therapies work in this direction to relieve the stiffness of the blood vessels so the heart can pump. If you give the heart less work to do, it works better. None of our medications cure this disease. This is not a disease that can be cured with medications. These medications, our goal is to slow the progression of this disease, and some patients respond to therapy better than others. Some do wonderfully, some do less wonderfully, but all of the medications for pulmonary arterial hypertension work on this very basic principle. The blood vessels have gotten stiff and they're straining the heart. Let's see if we can get them to go in the right direction. So what are these treatment options? Viagra, anybody? So all the medications work in the same direction. Probably the one that everybody is familiar with is Viagra, and this is usually where I get a giggle in my office. Now, pulmonary arterial hypertension happens more in women than in men, so I definitely get a giggle when I tell women I'm going to put them on 3 times a day Viagra every day for the rest of your life. So there are a lot of vasodilators. I put this one up because it's the one everyone knows. Someone mentioned it earlier, Revatio. They were put on it for their Raynaud's. It's another place that we use it because it relaxes blood vessels. We use it to relax the blood vessels in the lungs, but it can actually also relax the blood vessels in the fingers and relieve your Raynaud's. So someone mentioned it earlier. Sometimes we use some of the other medications as well. Now, is Viagra all we have? Absolutely not. It's just the funniest. Oh boy. This is the list of medications, and I think this is an amazing list. Why do I think this is an amazing list? Because in 1995, this list didn't exist. Before 1995, we had Coumadin. We had calcium channel blockers, which only worked for 15% of patients with this disease. That's what we had. And so before 1995, there was absolutely nothing that impacted the course of this disease. Before 1995, our patients were getting sicker, getting more short of breath, suffering and dying. Our patients are still getting sicker and suffering and dying, but less so, more slowly. And it's because since 1995, we've gotten therapies. So Flolan came out in 1995, and this changed the face of pulmonary arterial hypertension. And since then, research has been furious and passionate about treating this disease, and this is where we are now. And we haven't stopped. New therapies are being developed all the time. And these therapies do not cure this disease, but it does slow it down in many, many patients. It does improve quality of life in many, many patients. And in just the last 6 months, 3 new therapies. They all work well, different therapies for different patients. And so there's not one right choice on here. There's a better choice for patient A than there is for patient B. And you've got to really tailor the medication and the combination of medications to the patient, their side effects, their other diseases, the severity of their pulmonary hypertension. But this slide gives me hope, because before 1995, it would have been just about empty. So in summary, dyspnea is caused by heart disease, lung disease, and the legs get in there too. Pulmonary arterial hypertension means high blood pressure in the blood vessels of the lung. And PAH is rare overall, but more common in scleroderma, so we need to have a high level of suspicion and look for it. It's important to rule out other causes of shortness of breath or dyspnea, now that you guys went to med school with me. The most important screening test for pulmonary hypertension, especially in patients with scleroderma, would be the PFTs, those lung function tests, and the CAT scan, and the echocardiogram. They get us most of the way there, but the diagnostic test is the right heart cath. And the treatment depends on the kind of pulmonary hypertension and the patient that we have. And those are all of my slides. All right, so we have lots of questions. I'm going to just go in order. Up here in the front.
What about the medications that you mentioned? Are they expensive? Will insurance cover?
Okay, excellent question. So, are they expensive? They are crazy expensive. So pulmonary arterial hypertension medications are some of the most expensive medications on the market. They're absolutely ridiculously expensive. Will insurance pay for it? For your kind of pulmonary hypertension, absolutely. This is the disease where the medications are designed to work. This is where they are studied. So pulmonary arterial hypertension, this is where they're clearly indicated. So insurance companies cover them. Now your copay is not always low. That depends on whatever insurance you have and what your carrier is and what your copay is varies. They cover them, but how well the copay is covered depends. Because this is such an important disease, we are fortunate to have several companies, groups that support our patients, and if the copay is high, help us with the copays. One of them you'll hear about often if we need is something called Caring Voice Coalition. It's absolutely amazing, and without them we could not take care of our patients. But also many of the drug companies also have their own patient assistance programs, because we all believe in this disease, and it's so very important that we make sure these therapies are available. So expensive, yes. Covered, yes. We have ways to get them affordable. Yep.
What do you do with your insurance company if your doctor sent in all the information, you're already on a medication, but you were on another insurance, and now for some reason this new insurance has to go through a process whether they're going to approve you or not. In the meantime, you're not getting medication.
So this comes up in most. I'll tell you first, your doctor, their nurse practitioner. We do this all the time. So and your doctor should be able to kind of troubleshoot this because it comes up. Essentially, you bang your head on the wall for a while, and then you sit on the phone. Usually, if you can get through, and the nurse practitioner, I couldn't do this without my nurse practitioner. She's amazing, and she does most of this for me, but you sit on the phone, and they'll usually give you an emergency dispensation for 30 days up to 90 days to cover you while they go through the paperwork. Sometimes you'll get pushback because your insurance company has a deal with this company versus that company. And then if you're already on the therapy, you write a letter saying, listen, my patient is stable and doing well on this therapy. I'm not changing. This puts her at risk. And I'll tell you, it takes a lot of work, a lot of paperwork, some time on the phone call, and headaches, but it gets done. So usually it's a matter of getting through to them on the phone and writing letters. But if you have PAH and you're on a therapy, you should be able to get this therapy covered.
Because they keep offering Revadio.
So
I'm on Encirca.
Uh-huh.
So I want to change it, but I'm doing fine on Encirca.
So what I didn't talk about on that previous slide is that we have three main categories of medications. Adcirca and Revadio are in the same category of medication. They work in kind of the same way, the same receptors. And so different drug companies make different deals with different companies. Usually, if you're already on the therapy, you write a letter, you fight, they will not force you to switch. Sometimes you can't win that fight, but it's actually pretty rare. And it's really a challenge letter talking about not wanting to change therapy, side effects, the fact that you're already on it. A new start, if you haven't been started on it, usually you have to defer to them on which one you use, but if you're already on it unstable, usually you can show them there's no reason to destabilize a patient because it's cheaper for you.
Okay, I'll send the letter, thank you.
Yes?
What are your thoughts about any preventative medications for PAH?
So unfortunately, there is no preventative medication for PAH. The best we can do is having a low index of suspicion and always being vigilant, trying to find it as early as possible. The research does suggest that the earlier we find it, the sooner we treat it, the better chance a patient has of improving and actually staying stable. The more advanced the disease is when we find it, the crazier the blood vessels have gotten, the harder it is to recover, the harder it is to keep you stable. So what I usually advise is in patients who have a high risk or have any of the symptoms that are worrisome, have a low threshold to do an echocardiogram. We should be doing lung function tests pretty routinely because they're a really good way, especially in scleroderma, not necessarily other forms of PAH, but in scleroderma, to have a clue about this evolving, but have a very low threshold to do an echocardiogram. If the shortness of breath is changing, if they're slowing down, if you don't know why, if there's any ankle swelling, their oxygen is falling, and these are things we should be looking for, just do the echocardiogram. It's a good screening test, it's quick, it's painless, there are no side effects, and finding it early is better than finding it late. And if you're not sure, if the echo is in the middle, indeterminate, unclear, do a right heart catheterization, just find out. If you're not sure and you're not comfortable with the disease, send them to see somebody who does. I'm biased, but I strongly believe pulmonary arterial hypertension should be managed by somebody who does a lot of pulmonary arterial hypertension. The drugs are young, the side effects are multiple, and you want somebody who's proficient in it. Yes?
I heard what you said, there's no preventable medication or anything. What is exercise, such as swimming and working out? You know, does it help in any way, or is it just good for everybody, but nothing special for this?
It's good for everybody, and it's special in this. As you're, let's see if I can go backwards. So, I may not need to. Oh my goodness, animation. So when you look at this system, as the heart and lungs slow down, if you think about them like a car, they're providing less fuel to the legs, which are the machine that's got to go, go, go. When you are out of shape, when you're short of breath, you stop moving. When you stop moving, the muscles are lazy, they get weaker. When they get weaker, they demand more fuel to do the simplest things because they're weak. Then they demand more from the heart and lungs, which were sick to start, and so it can't deliver more. So they get more out of shape, which means they demand more, and you get more out of shape, and you get into this spiral where the heart and lungs have whatever limitation they have, but the muscles are now getting into the game and leading and causing shortness of breath just by being out of shape. So my patients, as soon as they're safe to do so, and if they're safe to do so the day they walk into my office, I'm going to treat their pulmonary arterial hypertension, and I'm going to send them to rehab. Because the better shape you're in, the more you can do with whatever you've got. It keeps you stronger, it keeps you going longer, and it actually improves your recovery as we work on getting your heart to work better. Hang on, I'm going to keep going. Another question?
I'll piggyback on that. Is
There's
there
a-
a better exercise for that than just general exercise?
So there's no one exercise that works well. I mainly tell patients to get up and move. Focus on what you want to do, right? Your quality of life. It's great if you've got muscles in your arms, but really what you want to do is be able to get up and dance, right? So teach your legs to do what you want them to do. Get up and walk. Walk on the treadmill. Walk outside. Use your legs and get up and move. It doesn't help, again, it's not preventing pulmonary hypertension. It's not slowing you down, but that's actually where quality of life is coming from. Right, is whether or not you can get up and do the things that you want to do, go where you want to go, see the people you want to see. And so I really focus on making sure we use the muscles in our legs because that's what's going to carry you. Absolutely, you want to make sure your upper body is strong as well so you can carry things. But I mainly tell people, don't waste your energy carrying heavy things. Let your legs carry your body. There was a question down in front. Here, yes.
What is pulmonary rehab? Is it rather than if you went for like physical therapy?
So physical therapy really focuses in on usually a specific part of the body, strengthening the arms, stretching out the hands, strengthening the feet, working out a joint that's gotten stiff after you had a replacement. Pulmonary rehab really focuses on getting the overall body into better shape. They'll do things like put you on a bike and have you ride, working on those leg muscles. They'll put you on a treadmill and make a carry yourself. And as it gets easier, they speed it up, right? It's like a gym. And the good thing about pulmonary rehab is you are monitored. So they put you on a saturation monitor, so if you need oxygen, and usually most pulmonary rehabs, if you need oxygen, comes right off the wall so you don't have to push a tank. So we keep up with your oxygen needs, and you're monitored. And they check your blood pressure and the whole thing. It's like a gym, safe. Cardiac rehab is actually quite similar. So I will switch back and forth depending on the patient, what else they have going on, their insurance, what's nearby their home. If cardiac rehab's down the street, that's what my prescription says. If pulmonary rehab's down the street, I'll just change it to pulmonary rehab. Both of them work on getting you up and moving and rebuilding the body. And actually, as you get stronger and as the muscles get stronger, they up the ante and make you push it a little harder. And it's really a very safe, monitored exercise program. Yes?
So, the first, I have limited, and the first thing they did was send me for an echo and PFTs. How often do you do those if they're okay? Do you wait till you're short of breath, or do you do them, how often do you do them?
So there is no one guideline about when to do them. So I'll tell you what I do in my pulmonary clinic and what I encourage my fellows to do is depending on upfront, absolutely, I do PFTs, a 6-minute walk, which is essentially getting you up and moving you and seeing what your oxygen does when you walk and a blood pressure does. I do an EKG and often an echo up front, not always an echo up front, but I screen you heavily saying, okay, she's got scleroderma. Let's figure out what organs are involved. The lungs aren't always involved. Sometimes they are. It's often. Is the heart involved? What else is going on? And what is her baseline function? What can she do now so that when it's early, when that starts to fall off, I can have an early warning that even before she notices she's slowing down, how far she can walk. In 6 minutes is coming down. I'm looking for things that are going to be warning signs and so I need a baseline. Then if there's any interstitial lung disease, we usually do lung function tests every 3 months. Maybe every 6 months if you have absolute stability, if there's interstitial lung disease. I encourage people to do lung function tests at least every 6 months, depending on what they look like, but that varies depending on what your background disease is. The echocardiogram, it's kind of hammer nail syndrome. I look for PAH everywhere. I see it sometimes. I'm looking for it. So I tend to do an echocardiogram once a year, but that's probably more than you need to do it if the walk is stable, if there is no low oxygen, if the PFTs are stable. But I would say probably every 18 months to 2 years at the outside. But if everything else is stable, if everything else is not stable, or the patient is changing, or they're swelling, do it earlier. Does that kind of answer your question?
Yes, just the swelling in the ankles, not like your hands and stuff.
Yeah, so that's a really good question. So it seems like we all very, very much focus on the swelling in your ankles, and it's really just geography. What we're worried about is your body holding on to fluid. And the reason we focus on the ankles is that's where you're going to see it. When you stand up and walk around, gravity pulls that fluid down to where you can see it in your ankles. That's why in the morning everyone's got pretty ankles because you haven't had your legs hanging down. At the end of the day, they're swollen. So I encourage my patients, when we think about holding on to fluid, look where you're going to see it. Look in your ankles and look at the end of the day when it's going to be the very most and gravity is telling you what's going on. So it's increasing amount of swelling at the same time of the day telling you that you're holding on to fluid. And so the ankles are really not the problem. The ankles are the tattletale that you're holding on to fluid. But if you have your legs up all day, they're not going to tell you anything. And that's why sometimes it's in your abdomen. So someone who is bedbound, they will have swelling in their legs, or it will be where gravity's pulling down on the back of their calves, the back of their thighs. We're looking for any signs that you're holding on to extra fluid. As the heart the circulation, the lungs get sicker. As it works less well, the body holds on to more fluid. And so that's one of the early signs we look for is someone who's holding on to fluid. The more advanced the disease gets, the more you tend to hold on to fluid. But you can hold on to fluid just because you like salt. You can hold on to fluid just because you have left heart failure. So there are a lot of reasons, and so it's really the trend. New edema, new swelling at abdomen. Something is different.
I didn't actually see the swelling. I didn't have swelling in my ankles or anything, but I just had an echo week before last, and I have fluid around my heart now. So, I mean, I almost died when he said, you have to cut your liquids to a quart a day. And I'm like, I drink way more than that. So, I feel like I'm just sipping instead of drinking.
So, like I said, the ankles are really just a tattletale, but they're actually not the problem. If you just had swelling in your ankles, wear socks. The ankles are not the problem. The trouble is that you're holding on to fluid everywhere, right? So, the place that we will see it, for instance, if you come into the office, even before the ankle swell, you'll come in and we'll stare at your neck. We're looking at your jugular vein, right? I don't want to see it. If I can see it, you're holding on to fluid. It's a sign that the right side of the heart is straining. So before your ankle swell, I'll usually be able to see it in the office, but you can't see it at home. So I tell you to watch your ankles because you can see that. But there are other places, and the place that's actually dangerous, the thing I'm worried about is not whether the ankles are swelling, it's whether you're holding on to fluid. But the only place you're going to know it is looking in your ankles or getting on the scale and noticing you gain 2 or 3 pounds over 2 or 3 days. I'm a champion eater. I can't gain 2 pounds of fat in a day, but you can gain water weight. So if you're holding on to water, watching the scale will tell you, that's 5 pounds in a week. That's water. If you look at your ankles and your socks are leaving deep indentations and they didn't used to, that's water. And the issue is that you're holding on to water everywhere.
But the more water you drink, I thought helps flush that out.
Nope. So this is a common misconception. So first, the main issue here is not what you're drinking. In the body, just to confuse things, fluid is actually a salt problem. So salt is the main driver of thirsts in human beings. So every time you eat something salty, your brain's going to say, I got to dilute that, like making soup that's too salty. And it'll drive you to the sink, it'll drive you to the fridge and make you drink to dilute the salt you just ate. So that's why after the big game and you eat pizza or buffalo wings, you drink tons of fluid because of the salt. And then your ankles swell because you held on to all that fluid to dilute the salt. So the most important part of managing edema, managing fluid retention, is actually managing salt. So I focus on my patients about looking out for the salt. Salt is in everything. The average U.S. diet probably has about 4,000 milligrams of salt. If you have, I know, it's ridiculous. That's the face I make. The average, what should you be eating? A healthy person should be eating less than 2,000 milligrams of salt. If you have any heart dysfunction, 1,500 milligrams, and sometimes we're really cruel, and we say 1,000. That, I think, is impossible. But where is it? Well, you go out and you buy your Campbell's Chunky Soup, whatever you want. Corn chowder, clam chowder. I'm a Massachusetts girl. It's clam chowder. It's got your daily's worth of salt. 1 can, 1,200 milligrams, done, done, and done. Right? So canned foods, loaded in salt. When you go out to dinner and you've got the pasta with the cream sauce, a little bacon in it, you're done for 3 days. Salt, 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 salt. Lots of breads, the best ones. The fresh bakery breads, salt, salt, salt. Pizza, cheese, all the good things. And it's not that you need to give them up. You need to be aware. You need to choose where you get your salt, right? You want soup? Don't open a can of soup. Go make it. Or buy the low salt soup. You just have to have the clam chowder, all right, but you're done for the day, which means you didn't have cheese. You didn't go out and buy a bagel and slather it with cream cheese, right? You didn't have pizza for dinner because you chose your clam chowder that day. So it's just being aware that salt is in everything you buy, and you shouldn't be adding salt. I tell patients, you have a salt shaker, kiss it goodbye and throw it out, right? Because the salt's already there in absolutely everything you're eating, and if you're salting your food, it's gone. I had one patient, she goes, I don't salt anything. I put a little adobo, garlic salt, ginger salt, and then I cook it. Turns out, you can't cook away salt. If you put it in before you cook it, it's still there when you ate it, right? So anything that has salt on the end, get rid of it. Now, I'm going to get sued, but Mrs. Dash is maybe the worst tasting thing ever. There are lots and lots and lots of replacement salts. But also, we are all so used to eating salt that your tongue is numb to it. Right? Your taste buds are numb to it. It's really hard to give up salt, to cut it back. But after a while, you'll find actually everything tastes too salty. Your taste buds come back alive and resensitize to the salt. But you just got to give it up, because that's what drives you to drink a lot of fluid, and that's what makes you hold on to the fluid, because your body's trying to dilute all that salt you ate already. Most people, young people, healthy people, they get away with it because their kidneys will just get rid of it, right? Tons of salt, tons of fluid, pee it out, all good. But the sicker your heart is, the older we get, you've got heart failure, you've got diabetes, you've got high blood pressure, you've got pulmonary arterial hypertension, your body's not going to get rid of it. And actually, it's going to put more strain on your heart. And actually, it can put you into heart failure. And actually, it can make your pulmonary hypertension put you in the hospital, no matter how well you're doing on your medications. So salt management, fluid management is absolutely essential.
Can I ask you a question on that? Because Dr. Sindorfi earlier said you should take half your body weight in ounces of water that you drink. And like, you know, and I have an issue because like I can't lose the weight, and I eat, most of my food comes from the outside aisles, outside of dairy, you know, green smoothies, oatmeal and stuff. And the only salt I use is sea salt.
So sea salt's still salt. It's got less sodium chloride content, the bad salt in it, but it's actually still salt. And so sea salt, it's less, but it's not good enough if you have pulmonary hypertension. Right? Most people eat tons of salt, and no worries. Thank you guys for staying so late. Most people eat a lot of salt, and their body will get rid of it. And mostly it doesn't matter. If you have high blood pressure, if you've got pulmonary arterial hypertension, it absolutely matters. As far as the fluid intake you have for most patients, if you need fluid, you'll be thirsty, and you will drink. Some people just are in the habit of drinking a lot of fluid. And so I focus on salt, but then I say, also, a 2-liter fluid restriction. Right? Usually, if you can respect the salt, you don't actually get thirsty enough to drink 2 liters of fluid. But some people are just habit drinkers. I'm a habit drinker myself. Right? You have to make sure you're actually not overloading the body with fluid. Usually, the fluid is easy to respect and stay under if you watch the salt. Needing to drink 8 glasses of water a day, it's actually, there's no magic to 8 glasses of water a day. You need to stay hydrated, but you don't need to overhydrate. Drinking more fluid is not going to wash out the salt. Your body will get rid of it. It does dilute it, but you still have to pee it out. When you have pulmonary hypertension, your body's not really good at figuring out, hey, I should get rid of that extra fluid, and it strains the heart. Yeah?
You didn't mention anything about oxygen. If you could, like, when do you require, what are the numbers?
What are the numbers? So not everybody needs oxygen, and patients who have just pulmonary arterial hypertension or even mild interstitial lung disease have oxygen that's not normal. Normal is 100 sitting still. Normal is 100 jogging a marathon. That's what normal is. Good enough is a totally different thing. Good enough is around 89%. So if your oxygen levels stay above 88, 89% on exertion, then you don't need oxygen. We're all built with reserve. 89 is good enough, and it doesn't make any difference to your body, to you, to your function, to your energy level. If you're 89 or 95, your body feels the same. Now, if you're dropping below that, then you need to be on supplemental oxygen. And it's actually especially important in patients who have pulmonary hypertension if they're dropping below that, because low oxygen over time can actually make those blood vessels get stiffer and faster. So that's part of your 6-minute walk. We check to see what your oxygen is doing when you exert yourself. Any other questions? All right, you guys have been fabulous troopers.